Faith Forward Media. This is Healthcare Musings. I'm Dr. Hassabolus. Welcome to Healthcare Musings. Happy to have you with me. Okay, so my nickname in the intensive care unit is Dr. Hassabolus. And the reason is, almost always when there's hypotension, I will bolus with fluid or colloid. Because I think it's a quick, it's easy, and it's frequently effective. Not always. Sometimes you need to go straight to vasopressors. At the same time, I gave boluses so much that the nursing staff called me Dr. Hassabolus. And Dr. Hassabolus has been vindicated by the literature, which is what we're going to talk about today. So they've done studies where they show people with the people who died in the intensive care unit had a huge positive fluid balance, right? Liters and liters and liters. And so the conclusion was, well, it must be because they just got too much fluid. I have a problem with that analysis because if somebody is septic shock, for example, and is on antibiotics and multiple vasopressors and antiarrhythmics, and you're going to have all those things have fluid and they're in fluid. And so if you have norepinephrine and epinephrine and dopamine and vasopressin and phenylephrine, all of those there's fluid. And then if you have antibiotics, that's more fluid. And if you have tube feedings, that's more fluid. Yes. And then so the sicker you are, the more pressors you need, and you ultimately die, you're going to have a positive fluid balance. That doesn't necessarily mean that the positive fluid balance in and of itself, right, led to the mortality. Number one. Number two, if you just give fluid willy-nilly, that does cause organ edema, it does cause tissue edema, it can cause problems. It can cause volume overload and go into the lungs and go into the tissues and the kidneys and the gut. There's no question about that. In the heart, you can get pericardial effusions and pleural effusions and ascites. There's no question. Like with acute pancreatitis, a lot of times, the fluid will leak into the abdomen and cause abdominal compartment syndrome. So I get it. It's not just you can just give fluid unlimited and it doesn't cause an issue. It does. Fluids are drugs. They're like any other drugs, and they have complications, especially normal saline. Too much normal saline, and I've seen it, can give you a non-gap acidosis. So there's no question about that. And when you put it in the literature, when you do a randomized trial, Dr. Hassabolus has been vindicated. So I just want to go over those studies. There's two main ones. One was published in June of 2022, and the other one was published in February of 2023. They were both published in the New England Journal of Medicine. The first study was the classic trial, right? And it says restriction of intravenous fluid in ICU patients with septic shock. And again, I am in the aggressive camp with septic shock. I believe at least you give 30 mLs per kilo initially. And if they continue to be fluid responsive, you continue to give them fluid. During the COVID pandemic, people would come in frequently dry, and people were like, "Whoa, we're going to keep them dry." Yeah, but not at beginning. Not if they're dehydrated and having diarrhea and vomiting or haven't eaten and they have all this insensible water loss. You got to give them fluid. You got to volume resuscitate first. You got to fill the tank before you do pressors, or at least fill the tank while you're giving vasopressors. You don't want them to be hypotensive too long. So this study published in the New England Journal, June of 2022, they enrolled 1,554 patients. 770 were assigned to the restrictive fluid group and 784 to the standard fluid group. And their primary outcome data was death from any cause within 90 days after randomization. And they found at 90 days, death had occurred in 42.3% of the restrictive fluid group as compared to 42.1% in the standard fluid group, right? And this was not statistically significant. And in the ICU, they said serious adverse events occurred in at least once in 29.4% in the restrictive fluid group and 30.8% in the standard fluid group. But that wasn't statistically significant. And then also at 90 days after randomization, the number of days alive without life support and days alive and out of the hospital were similar. So in my mind, and it's very interesting how you can interpret the data. In my mind, I've been vindicated that aggressive fluid group. It's not necessarily aggressive, standard fluid, and the difference in fluid is like not that much. Like the standard fluid group had a median of 3,800 cc's, 3,811, and the restrictive, well, actually had 1,798 ml. But the interquartile range varied greatly, right? The maximum of the interquartile range was 6762 in the standard fluid group, as opposed to 4366 in the restrictive fluid. So there is some meaningful difference, but again, 2 liters approximately is not, a huge difference. So it's not like that, the standard group got 12 liters and the restrictive group got 2 liters, right? At the same time, no difference in outcome. And so they're saying, see, restrictive fluid is good. And I say, see, aggressive fluid is fine as well. Then they did another trial. This was called the Clovers trial, published in February 2023. This time, it was an unblinded superiority trial, okay, and they enrolled 1,563 patients. 782 were assigned to the restrictive group and 781 to the liberal fluid group. They also found, again, the primary outcome, they hypothesized that all-cause mortality before discharge home by 90 day would be lower in restrictive fluid strategy than with liberal fluid strategy. Okay, that was their hypothesis. And they found that death from any cause before discharge home by 90 days occurred in 14% of the restrictive fluid group and 14.9% in the liberal fluid group, not statistically significant, right? So, again, here's their conclusions. Among patients with sepsis-induced hypotension, the restrictive fluid strategy that was used in this trial did not result in significantly lower or higher mortality before discharge home. So again, they wanted to show that being restrictive fluid group would be better. It wasn't. And they said, but it wasn't worse. And I'm saying, but it's not better, right? Dr. Hassabolus is vindicated. Then, these were 2 in the New England Journal. Then in CHEST, they did in 2023. They did a updated systematic review with a meta-analysis. What they said was the meta-analysis of all-cause mortality in 8 trials with low risk of bias showed relative risk of 0.99 with a confidence interval crossing 1 with moderate certainty evidence, and 6 trials with predefined definitions of serious adverse events showed a relative risk of 0.95, again crossing 1, and they found that. And so they found no difference in outcomes. And their interpretation is, among adult patients with sepsis, lower IV fluid volumes probably result in little to no difference in all-cause mortality compared with higher IV fluid volumes. But the interpretation is limited by imprecision in the estimate, which does not exclude potential benefit or harm. Similarly, the evidence suggests lower IV fluid volumes result in little to no difference in serious adverse events. Once again, Dr. Hassabolus is vindicated. It doesn't mean that doesn't mean it's better. It's just this belief, and they keep studying it, and the outcome shows no difference. This is very similar to targeted temperature management after cardiac arrest, right? They kept studying it over and over and over and over, and each time it showed that hypothermia, therapeutic hypothermia, which is called targeted temperature management, did not result in any better outcomes for people with cardiac arrest. And they kept studying it over and over and over, and it kept showing the same results. And after that, I'm like, I'm done, right? Preventing fever is one thing, but cooling them down to 92 degrees to 33 centigrade didn't make any difference. And they just kept studying it, and it kept saying the same thing. Dr. Hassabolus has been vindicated. And so the European Society of Intensive Care Medicine, in their 2025 clinical practice guideline on fluid therapy in adult critically ill patients, they say that in adults with sepsis or septic shock, the guideline suggests administering up to 30 ml per kilo of intravenous crystalloid in the initial phase, with adjustments based on clinical context and frequent reassessments. It's a very low certainty of evidence. And that's what I believe. I believe, and very beginning, minimum 30 ml. They say up to, I believe, minimum 30 ml per kilo initially. Get them resuscitated. Fill the tank. If they continue to be fluid responsive, keep giving fluid until they stop being fluid responsive. If they are no longer fluid responsive, then stop. Okay, and if they are still hypotensive while you are resuscitating, because sometimes it takes time, then definitely start vasopressors. Don't just keep giving fluids willy-nilly, because it can cause harm. It's not, again, these are drugs. It's not unlimited, and it's just not free. Yeah. So, 100%. That's what I believe. Aggressive. When I was training for the marathon way back, right after 3 miles, I would down a liter of like Gatorade or Powerade. A liter, not a 250 cc cup of coffee, right? Which is what the 250 cc bolus is. It's a cup of coffee, and we give that cup of coffee over an hour, okay? Or if a 500 ml bolus over an hour is like a bottle of soda. Right? We don't do that for ourselves, but we do that for our patients and think we're doing something. So if they are volume if they're volume depleted, you replete their volume as much as you can, right? And then once they stop being fluid responsive, they don't. And so I wanted to get Dr. Matt Hoffman's opinion, because he runs that wonderful Pulm CCM Substack, and I asked him about I told him I was going to do this podcast, and this is what he said, quote, "Those who consider themselves expert at ultrasound or other methods of measuring fluid responsiveness might be comfortable restricting volume resuscitation in the early phase of sepsis. I suspect most other clinicians continue to follow the bolus now, diurese later management strategy for most patients in shock from sepsis," unquote. That's true. Like if you have sophisticated ultrasound and you can tell and you can look and see, okay, are they fluid responsive or they're not fluid responsive? Okay, then maybe you can get away with being restrictive. Most of us don't do that. Most of us who take care of patients aren't able to do that. And so I completely agree. I think we should be aggressive with volume resuscitation in the beginning, and if they stop being fluid responsive, we stop giving fluid, and then we go to vasopressors as soon as possible to minimize the time to hypotension. So, once again, Dr. Hassabolus has been vindicated by the literature. They keep trying to study this, and it keeps saying the same thing, that restrictive therapy is no better than liberal. Doesn't mean liberal is better either. Yes, I agree. But still, in my mind, and it's just interesting how different people interpret the data, but in my mind, Dr. Hassabolus has been vindicated. Thanks so much, guys, for your time and attention. And until next time, Dr. Hassabolus signing off on Healthcare Musings. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.